Hello, my name's Joel Dunning. We're here at the STS 2024 and I have the great delight of being here with Professor Ralph Damiano. It's an absolute delight to be here with you, and we were just recollecting that our first chat was back in 2011 about atrial fibrillation back in Geneva. We had the most wonderful talk, and I do recommend you actually go back and look at it. It was a really good chat about that, and you of course took on the mantle of Jim Cox, who you know very well and who is still working, and one of just the world's best proponents of atrial fibrillation surgery. And today you've been in a session all about atrial fibrillation, and there's some really interesting breaking news in that, including STS guidelines. So maybe you could start by just telling us a little bit about that amazing session and about the guidelines that you were discussing.
Yeah, Joel, it's always great to talk with you, and especially about atrial fibrillation, which you know is an area of real interest for me. The great thing to look 2011 to now, the huge amount of progress we've made. And not only in developing less invasive surgical approaches and totally innovative new approaches based on different technology and hybrid collaboration with electrophysiologists, but also in accumulating evidence that really suggests the importance of surgical ablation. The session started out by talking about the new STS guidelines for surgical ablation of atrial fibrillation. And I think it's dramatic to look now of how strong our recommendations can be based on excellent clinical evidence that we need to be doing this. I think some take-home messages for the surgeons out there and for all physicians treating atrial fibrillation is now we have really the highest level evidence supporting the efficacy of surgical ablation, particularly during concomitant surgery. So we now have 13 or 14 randomized trials that have looked at patients being referred for mitral valve surgery, which is still by far the most common indication for surgical ablation in the world today. It makes up maybe a third to 40% of all ablations. But now we have multiple randomized trials. All have shown that surgical ablation has a significantly better restoration of sinus rhythm. But now we have a number of large retrospective and prospective population-based studies, not randomized trials, but show that surgical ablation really, without much question, improves survival. So we know it's effective at restoring sinus rhythm. We know it improves survival. So therein, we now have a 1A, the highest level of recommendation for concomitant ablation during mitral surgery. But in these guidelines, even during CABG and aortic valve surgery, because of the really pronounced survival benefit in these population-based studies, that there's a 1A recommendation also in those populations to perform surgical ablation. So I think now we have very strong evidence that performing ablation not only gets patients back into sinus rhythm, which is a big deal for most patients who are in AFib if you talk to them, but improves survival. And that survival benefit, we were one of the studies in a propensity match study, was a 20% survival benefit at 10 years. So that's non-trivial. And I think there was another presentation looking at longitudinal outcomes from the Medicare database showing the same thing in this session. So I think the big thing in the new guidelines is if patients who are being referred to you as a surgeon, they have AFib, you have to treat them. And the other big change in the guidelines is that if you look back to 35 years ago when Jim Cox introduced the maze, we've always with a maze procedure managed the appendage. It was always part of it. You took the left atrial appendage off. And we had some great retrospective case series data that seemed to decrease the stroke risk in these very high-risk patients. And as most people know who are listening, the most dreaded complication for AFib is really stroke, and it increases your risk of stroke 5 to 6 times. But finally, with the LAOS 3 trial, which is a big randomized trial that Richard Whitlock performed, multi-center international trial. If you have your appendage occluded during a surgical procedure, your risk of of having a thromboembolic event or stroke is going to be significantly less even by 3 years, and a dramatic reduction. So now managing the appendage, which was a 2A recommendation, we all thought it was a good idea, has now gone up to a 1A recommendation because we have a randomized trial evidence that it prevents stroke. We would assume that on the long term, that would also have a huge impact on quality of life and potentially survival if you get into the right patient groups.
Yeah, I mean, this is just such a massive difference to 2011 when we talk.
Yes.
I mean, it's the evidence. So, I mean, you've been doing these since then, so the technical part's been worked out, but now we really have that level 1 evidence. And as you say, the Laos trial, our unit was even a participant in that. You know, it's absolutely smashed it out of the room, didn't it? So what would you say currently today are the barriers to surgeons actually occluding the appendage in concomitant surgery, and it's CABG as well as mitral, anybody in atrial fibrillation? What do you think the barriers are that exist out there?
Yeah, that's an excellent question, Joel, because another presentation during this session was from Dr. Badwar and his group from West Virginia, where they looked at the US Medicare database from 2018 to 2020. And what they showed, and this is now in an area, this is just mitral patients, where it's hard to understand the present treatment patterns in the US, because for a mitral patient, you know, you're already on bypass, you've opened the left atrium. I mean, doing a maze, it's all set up for you. You have the perfect ablation environment to do the maze. Yet even in this relatively recent study, only 45% of patients receive surgical ablation. It's just tragic. And about a third of the patients weren't even getting their appendage occluded. So, you know, we have a lot of room for improvement. What are the barriers is a good question, and we discussed that at this session. I mean, clearly there's an education barrier. I still think that a lot of surgeons either didn't learn how to do a maze procedure or any type of ablation while in practice, and haven't really been able to get up to speed with it since then. So I think education still is first and foremost a big issue. If we don't go back 11 years, but we go back 20 years to 2000, I think it is important that only about 1% of patients received a maze who are having mitral surgery. So another way to look at it would be, hey, we've gone from 1% to 45. That's pretty darn good. But we need to, you know, for something that's a 1A recommendation that, you know, restores sinus rhythm, improves survival, and now we show that appendage occlusion definitely prevents stroke. You know, we should be doing it certainly more than 50% of the time. I think it's education. I think we're going to have to make it potentially there's a discussion of making it a quality metric so that if you don't do it, you know, that would state that maybe your program wasn't of appropriate quality. I think we also need to get out to patients and to our referring cardiologists that this is something that has to be done. We have now very good evidence. What will be coming out also this month is the new HRS, Heart Rhythm Society. It's also international guidelines on catheter and surgical ablation, and we'll equally have 1A recommendations for appendage occlusion and for mitral valve ablation. We really need, as surgeons, to do a better job. I think, as someone who spent his life in surgical education, I feel like we've somehow got to do a better job of educating surgeons. I think there's still a lot of confusion in the field, and I think everything we can do to try to standardize and potentially simplify the operations as much as possible that still don't sacrifice efficacy, I think will be important. But I would imagine that with, you know, these are the first guidelines that are this strong coming out. I think you're going to see a change in practice pattern in the next 5 to 10 years.
So clearly things we do here are it'll increase my bypass time, it'll increase morbidity for the operation, and then, as you say, you know, I don't know how to do it. So is there anything you can say about the morbidity, increasing bypass time, and also do you have to do left side and right side and everything? Can we do a little bit less? You know, how can people sort of address all these fears?
Well, I mean, I think, you know, there are obvious of issues with surgical ablation going back decades. But now we have a lot of randomized trials that you could argue have addressed that. We have not shown in either the randomized trials or in the big prospective databases like our STS database here in the US, that doing ablation has any effect on mortality. And in fact, the STS study showed that it may decrease 30-day mortality a little bit. So it doesn't impact mortality. Does it add to bypass time? Yes. But if you're improving someone's survival by 20% at 10 years, that's certainly worth an extra 10 to 20 minutes. As Dr. McCarthy said, I think it probably takes an extra anywhere from 10 to 30 minutes of time to do an adequate ablation. I think the benefits you get in both restoration of sinus rhythm and survival are well worth that. I mean, we don't really think about, for most of us, it takes us 30 to 90 minutes to do a really good mitral valve repair, depending on how complex. And we don't say, well, that's not worth it. Yeah. Of course it is worth it, because you don't want to leave the patient with severe mitral regurgitation. So I think, and that's both training surgeons and providing some good proctoring, but also just educating that we don't really talk about that. We don't talk about, doing IMA grafting during bypass grafting takes longer than sewing veins on, but we all now would never do that. So I think we have the data to suggest that it's well worth the small time investment. The other thing is that I would hope all surgeons remember, it's a once in a lifetime opportunity to treat AFib, particularly if you're doing mitral surgery. The patients are on bypass. The heart is empty. You have a perfect ablation environment. The cardiologists would give their lives to have one day where they could actually see what they were ablating and to use tools that we know between the bipolar clamps and cryo are always transmural. So you have this the patient's not coming back again. To spend a little extra time, I think that's well worth it. And not even a question in my opinion, but of course I am a long-term believer in this. But that's the issue. Now, how often do you have to do biatrial versus left atrial? In St. Louis, we're interested, if I have that chance, if you're coming to me for mitral surgery and you're 40 years old, I don't want to treat the AFib you have today. I would like to also treat the AFib you might get when you're 70. So in my opinion, the right atrial lesion set is done on the beating heart. It does add to bypass time, but not at all to cross clamp time. And it probably increases the success anywhere from 10 to 20% long term, which we'd imagine we're never going to have a trial to show that matters for survival. But I think, in my opinion, why not? I think it's a comfort level. We know from mapping studies on our patients that about 10 to 20% of AFib is from the right atrium. If you have tricuspid regurg or any pulmonary hypertension, it could be in a higher percentage in those. So, my feeling is initially as you get going, doing a good left atrial maze is the really bedrock and the foundational principle to all surgical ablation strategies. But as you get more comfortable, you're going to probably want to, certainly in the mitral population where your left atrium is open and you're on bypass, there's little reason, in my opinion, not to do a biatrial. But, some people do feel time pressure. And, one of the things we're working on in the lab, and this is an area that I hope the young surgeons listening to CTSNet will take as their areas of research interest, is if we could better define the AFib substrate, I think we'd be able to better define a more localized operation. But right now, when anyone comes for surgery, we have no idea really what's causing their AFib. We just knew they either have paroxysmal or persistent, and we try to treat it. But there are now some non-invasive imaging modalities that may give us some better ideas going forward, and we can maybe tailor the approach. But I think what we'd have, in 2024, we know that not pulmonary vein isolation, but isolation of the whole posterior left atrium is critical. And that should be the foundational principle, creating a box that isolates all the pulmonary veins in the back of the left atrium. And then everything you can do above that, I would think, will be a real benefit. We were just discussing before this, there's now a bipolar clamp that can do that box isolation with a single application. And we're just about to start a trial to see how effective, how much, is that as effective as a maze, less effective? If so, how much less effective? But, one of the things we touched on in the session is, maybe giving up a little efficacy, doing nothing is 0% effective. And that's now what the majority of patients get. So maybe if we can make something a little simpler, but maybe it was 70% effective, but then we could treat 80% of the patients, that may be a valid trade-off. But we're still wanting for data and some evidence to guide us, even after all these years.
Right. So as a final message, if somebody's out there saying, okay, I'm going to start, would it be acceptable, just one box lesion to the left atrium and clip the LA appendage, and better than nothing, isn't it? Could people start with that? Or
I think it's not a bad place to start, but if you're doing mitral, I would also we call it the left atrial isthmus. So you take a lesion, if you're depending on what technology you're using, but just one line of block between somewhere on the box and your left atrial, your mitral valve annulus would prevent flutter. But I would generally agree with you. That, to me, is a foundation. We know that without isolating the back left atrium, even the rest of the maze does not work well. So that, I would say, is sort of the bedrock principle, where after that, then I think we do need some more data on what exactly for each individual patient would be needed.
Right. Well, it's so good talking to you as ever. It's fascinating. I loved talking to you earlier about your time in England, in Newcastle and Middlesbrough, and your wild stories. You should write a book, I think, really. And,
yeah, I don't know if I'll have a very big circulation. But
And I guess if it took 30 years to get from 1% to 45%, then you're halfway through your mission, aren't we? So hopefully in 30 years' time, we'll have another chat and it'll be a full success. Well, it's so good to talk to you, Ralph. Thank you very much.
So great to see you again. Really enjoyed it.